So after so uh, after hearing so many treatment papers, now I am coming to some basic aspects from pathology to practice. So when we get a colorectal resection sample, so we are bound to give a report like this, describing so many variables, but we follow actually synoptic report, and for the synoptic report we need some help from our clinical colleagues, from our surgical colleagues, especially the type of specimen, the radiological findings. So we need this type of information for examination of grossing. So the procedure, we need to include here the tumor site, then the tumor size, and most important is if there is tumor perforation. So if there is tumor perforation, so tumor perforation has got tremendous effect. So what is perforation? Perforation is a gross defect on the tumor, which actually communicates the internal tumor to the exterior. So if there is tumor perforation, it is T4. Now sometimes there is iatrogenic tumor perforation. Again, we as a pathologist, we cannot understand whether it is iatrogenic or it is the original perforation. So we always try to communicate to the surgeon, whenever there is a perforation, you please mention whether it is iatrogenic or not. And the iatrogenic perforation can happen within the abdominal cavity, can happen outside the abdominal cavity. If it is within the abdominal cavity, still we write it T4. Sometimes perforation can happen proximal to the sample, not at the place of tumor, but proximal to the tumor. And in that case, it is not T4, but still the prognosis is very bad. So perforated cancers have higher mortality, higher operative mortality, higher 5-year local recurrence, higher rate of peritoneal carcinomatosis. Now the tumor type, about 40 to 60% tumors are conventional adenocarcinoma, and the next common is mucinous or colloid carcinoma. And these carcinomas behave, their behavior is some is good, some intermediate, and some are very bad. The good prognosis is adenoma-like adenocarcinoma, medullary carcinoma. These has got good prognosis. Now intermediate prognosis, adenocarcinoma NOS, mucinous carcinoma, adenosquamous carcinoma, poorly differentiated and poorly cohesive carcinoma, mixed non-neuroendocrine carcinoma, then large cell neuroendocrine carcinoma, sarcomate carcinoma with sarcomatoid component, carcinoma undifferentiated. So all these have intermediate prognosis. And bad prognosis is for signet ring cell carcinoma, small cell neuroendocrine carcinoma, serrated adenocarcinoma, and micropapillary adenocarcinoma. Next, histopathological grade. So how grading is done? If it depends upon the solid component. If the solid component is more than 50%, it is grade 3. If the solid component is less than 5%, it is grade 1. And if the solid component is in between 5 to 50%, it is grade 2. And if 100% tumors are solid, it is the signet ring cell carcinoma or grade 4. Now, how it actually helps us in determining the survival, overall survival. Here, The blue one is the 2-year survival, and the the brown one is the 5-year survival. So for well differentiated, you can see the survival is highest, and for the poorly differentiated, the survival is lowest. Now, extent of staging. Extent or staging, we all know TIS, T1, T2, T3, and T4. Regarding the leaf node, we know the N1, N2, and N3. Now, the most important thing is N1, which is again 3 types: N1A, N1B, and N1C. N1A means only single leaf node is involved. N1B is 2 to 3 regional leaf nodes are involved, and N1C, it is no leaf node is involved, but there is tumor deposit. So we'll discuss again about the N1C. So it is node negative but tumor deposit present. If there is one leaf node positive, then it will be N11. So patients with node negative disease have 5-year survival rate of 70 to 80%. In contrast, 30 to 60% in those with node positive disease. So survival can be improved in the latter group by adjuvant chemotherapy. Now, regional lymph node metastasis is incorporated into the N category, while tumor in non-regional lymph node is considered distant metastasis, that is as TM category. So sometimes we get sample, a colorectal sample along with lymph node, separate lymph node, but there was no mentioning that from where this lymph node was taken. So we usually include it as regional lymph node, but if it is non-regional, it must be mentioned and it should be sent separately so that we can put it in the TM category. Now, lymphovascular invasion, it is very important lymphovascular invasion. There are several types of lymphovascular invasion in colorectal cancer. Small vessel lymphovascular invasion, and its importance is if there is small vessel lymphovascular invasion, the patient will have lymph node metastasis. But venous or large vessel invasion, if it is venous or large vessel invasion, the patient will develop liver metastasis, especially if it is extramural venous invasion. Extramural means outside muscle. Outside muscle layer, if there is extramural venous invasion, that patient will show liver metastasis very soon. Now, which one is important? Lymphovascular invasion or extent of the disease? T important or lymphovascular invasion is important? Definitely, lymphovascular invasion is more important than T or extent of the tumor. Next, perineural invasion. Perineural invasion is, this is a nerve, and just around the nerve the presence of tumor. And what is the importance of this perineural invasion? 5 years disease-free survival rate was 4-fold greater for patients with PNI negative tumor. So 5-year survival rate was 4-fold greater for patients with PNI negative tumors in comparison with those having PNI invasion. So it is very important whether perineural invasion is present or not. Next, tumor budding. What is tumor budding? Tumor budding is single cell or a small cluster of less than 5 cells at the advancing front of the tumor. And there are 3 scores. Low means 0 to 4, intermediate means 5 to 9, and high means more than 10. So this is the tumor budding. The first one is no tumor budding. There is no infiltration, single cell or small group infiltration from that tumor. So it is 0 or no tumor budding. In the B, there are tumor budding. There are some single or small group of cells. So this one, you see the arrow mark is the area is the tumor budding. So here only 3. So definitely it is low score. It is less than 4. And then the C, it is intermediate. And D is the highest. It is more than 10. So it is the high tumor budding score. And what is the importance of tumor budding? Here you see the upper, the compact line is negative tumor budding, and the lower one is presence of tumor budding. So definitely disease-free survival is lower in presence of tumor budding. Tumor deposit. Tumor deposit is discrete macroscopic or microscopic nodules of cancer in the pericholic adipose tissue within the lymph drainage area of the primary tumor, but without identified lymph node disease, vascular or neural structure. And it has got adverse prognostic factor, and it needs adjuvant therapy to treat. And the important thing is this one, it is round nodule, but there is no lymphoid cell. So it looked like it is lymph node. And this morning I got a review case. There 9 lymph node was positive, but actually 1 was lymph node and rest 8 was tumor deposit. So if 9 lymph node is positive, then it is T3, or more than 9 it is T3. But 1 lymph node and other 8 tumor deposit, it is T1C. So it is very, very important to identify tumor deposit, and it should be differentiated from lymph node metastasis or tumor deposit, because N0 tumors without tumor deposit has got 91.5% 5-year survival rate, but no tumor with tumor deposit, only 37% 5-year survival. So it is very important to identify this tumor deposit. And this one is a very recent paper, a few months ago it came out. They actually analyzed a lot of cases, and then what was their result? You see the last one is their result, lymph node metastasis, then extranodal extension, and then tumor deposit. So tumor deposit has the worst prognosis, and if extranodal extension, its prognosis is worse than lymph node metastasis. So lymph node metastasis is the, if we compare these 3, is the good prognosis, and then extranodal extension, and the worst is the tumor deposit. So tumor deposit identification is very important. Here again the same thing, if there is tumor deposit, then the prognosis is very bad. Next, margin. Margin, we all know the circumferential resection margin, problems of circumferential resection margin. And if circumferential resection margin is positive, then its prognosis is bad. And if you do TME, you must mention in the requisition, and if possible, the resection margin, if you can mark resection margin, it is better for us, especially for our resident. They are not as expert as the surgeons to identify these margins. So incomplete mesorectum resection has got poorer prognosis. Now the distal margin. So when we call it the distal margin is free, here is a study, and they have shown that if the distal margin is 1 millimeter or less than 1 millimeter, in comparison to more than 1 millimeter, the 5-year local recurrence is 24% versus 12%. 5-year disease distant recurrence rate is 35% versus 20%. And the 5-year disease-free survival is 45% versus 69%, and 5-year overall survival is 69.2% versus 79.7%. So the surgeon must achieve more than 1 millimeter free margin, free distal margin. So we or our resident, they always do struggle to find out the margin. So non-peritonealized bowel margin actually is the margin, and we recommend surgeons considering marking the non-peritonealized surface so that we can actually clearly we can comment on the margin. Now the molecular studies, we all know the MMR, MSI, the interpretation of MLH, PMS2, MSH2 and MSH6. So the most important factors influencing prognosis and treatment: staging, lymphovascular invasion, tumor budding, tumor deposit and extranodal extension. So collaboration between surgeons, pathologists and treating physician is the key, and molecular studies, especially MSI, should be done in every case. Thank you very much.